So, thank you so much for having me today. I was very excited to receive this invitation. I'm a newer member of the board, but have enjoyed my time so far. And so it was really nice to receive an invitation from people I admire so much and work that I followed for many years. So thank you all for having me here today. Um, if you've heard me give a talk before, you know I give this caveat before every talk, but I'm often asked um, by people who are interested in this topic, what causes violence? And usually that means what is the one thing that causes violence? And I just need to note before I get started that there is no one thing. My colleague Rebecca White at Arizona State University said that challenges to society are not disciplinary, and solutions to these challenges will not be responsive to disciplinary or discipline-centric approaches. And community violence is no different. As a clinical psychologist, my research is from a clinical psychology perspective, but I view my work as one small piece of a very large and complicated puzzle. As some of you know, I moved to Texas A&M from a university in Chicago a few years ago. And so much of the work I will talk about today is work I conducted while I was in Chicago, as we are launching studies here in Texas right now. So positioning myself a little bit by training, as was mentioned, I am a child clinical psychologist. By profession, I'm a professor in the Department of Psychological and Brain Sciences here at Texas A&M, and I teach and also lead the Youth Rising Research Lab in the clinical psych program. I have multiple identities that I want to acknowledge, and this is probably not an exhaustive list, but I want to note this because these identities create a unique lens for the work that I do. My research program focuses on Black youth and families in disinvested urban communities. But as someone who grew up in a very small rural Southern town in a middle-class family, I do not have the lived experiences that the youth in my research studies have. And I think it's critical for me to note this because it means that I approach my work not as an expert, but as a collaborator with young people and families and communities. I need to also acknowledge how my position makes me feel about this presentation. If you are interested in community violence, a phenomenal book called A Peculiar Indifference by Elliot Curie um, talks about the often feelings of anxiety in discussing this issue. And what he talked about in that book resonated with me. And because I realized I'm really anxious at the prospect of talking about violence and the impact on Black youth. There is a fear that talking about these issues will play into longstanding stereotypes about Black people and crime. And so I recognize that the stereotypes are pervasive and there's no shortage of people ready to use them in the service of racist and regressive dialogue and social policies. And while these things make me anxious, I recognize the importance of this issue and we press on. But I do want to note all of these things as I begin the talk. And very quickly, we are the Youth Rising Lab at A&M, and we broadly study traumatic stress and mental health. And right now, we focus on community violence exposure and also traumatic loss, which is usually loss due to homicide. Um, and so just setting the stage, what is exposure to community violence, and what do we mean by that? And we're talking about acts that are interpersonal in nature. They are deliberate, they cause harm, but they are committed in a public area and sometimes by individuals who are not intimately related to the person who is exposed to violence. Sometimes they do know perpetrators, but not always. Some of the acts that fall under community violence might include assault, burglary, the use of weapons. Also, some measures include social disorder issues, such as hearing gunshots or the presence of drug sales in the community. And violence exposure is often separated into two types. There's direct victimization, which is conceptualized as a person being the object of these intentional acts. And then there's indirect witnessing. Sometimes people call this vicarious or secondhand trauma exposure. And this is when an individual either directly witnesses or hears about these sorts of events happening to someone else. Some key features of community violence exposure during adolescence that I think are important to point out. One is that violence exposure is usually described by young people as being uncontrollable. They don't feel like they have much control over the community violence that's happening in their community, don't believe that they can change it. For many young people that we work with, the violence exposure is repetitive and chronic. And we all know that uncontrollable and chronic stressors are the worst stressors for kids to experience. There are also increases during developmentally vulnerable time. So what tends to happen is we see an increase in community violence exposure as young people move into adolescence. And so this timing coincides with all of the other things that are happening during adolescence. My daughter just turned 16 yesterday. My son is 12, so I have a preteen and a teen, and you know everything that's happening for young people during that time. And so it's compounded. So violence exposure compounds those issues for adolescents who are dealing with normative stressors. And something we'll come back to in a bit. It's often regarded as a traumatic stressor because it's often associated with bodily harm to yourself or someone else, or the possible death or loss of friends, loved ones. And it is supposed to be outside of the usual experience according to how it's defined in the DSM. So my talk today is really I'm not gonna present one study. I'm really gonna talk about over the past couple of decades what we've learned um, through my work and the work of others on this topic, and kind of start thinking about ways of moving forward. So in terms of the prevalence, what do we know about the prevalence of violence exposure among youth? Well, we know that Black youth are disproportionately exposed to traumatic loss. Um, there are social stratification mechanisms such as racism, marginalization, and oppression that situate the development of Black youth in contexts that are characterized by systemic and structural barriers to competence and well-being. And so structural and institutional racism creates segregated communities of concentrated poverty and minimal or scarce resources. And those events lead to elevated levels of violent crime. These policies in communities create dysfunctional, crowded, underfunded schools, unsafe and unaffordable housing conditions, inaccessible or inadequate healthcare, food deserts, negligent and abusive policing, and lack of political representation or voice. And all of these things relate to elevated levels of violent crime. And this leaves African American uh, youth and families and communities that are systematically exposed to community violence. I no longer try not to use the term disproportionately anymore because these are systemic issues. And so this is systematic exposure to community violence. Violence is not about race, it's about racism and systemic and institutional racism. So I want to point that out, and that's why I have the term systemic in there. So many of you have heard the stats, and I'll talk about some stats related to something else in a minute, about homicide being the leading cause of death for Black males ages 15 to 30, that more Black men ages 15 to 24 die of homicide than the next 19 causes of death combined. It is also the leading cause of years of potential life lost for Black youth. My work focuses on something a little bit different. It focuses more on the folks who are witnesses or survivors of community violence, those whose trauma has often not been acknowledged, and those who have not been given space to grieve, because we focus on people who lose their lives, but those people are survived by youth who oftentimes remain nameless, the friends, the classmates, the brothers, sisters, cousins, neighbors, young people who must continue on with their lives carrying the loss and trauma of these incidents and many others. And our work has suggested very little change in this over time. An early study that we did with middle school students found that over 95% of Black youth had experienced at least one violent event during adolescence. Um, Following that up later with a different study in 2020, we found that this was with high school students that 96 to 98% had witnessed a violent event in the past year. Up to 80% had been victimized in the past year. And our findings are consistent with many other studies. Overall, the prevalence rate for Black youth in disinvested urban communities is high. I think it's also important to talk about the unprecedented spike that we saw in homicide rates during the pandemic, 2020 to 2023 or 2022. We saw these unprecedented increases in homicide rates. We now know, if you've been following any of the crime data, you know that the rates have fallen recently, but that 2 years was pretty rough, and we're going to be seeing the consequences of that for quite some time for young people who were exposed. So in addition to the prevalence rates, something else we've learned is that there's a lack of awareness about violence exposure among youth. There are some studies out there that have assessed how much parents know about their children's exposure to community violence. And the answer across all of those studies is very little. There are pretty high discrepancies between parents and kids reports, with parents, of course, saying that kids are exposed to lower levels of violence than youth actually report being exposed to. In general, these discrepancies are higher for boys, and the discrepancies increase as young people get older. Another study, or one of the studies in this group, found that the higher the discrepancy between parents and kids, the less likely that young people are receiving parental support for the issues they're experiencing around exposure. Another study that we kind of have penned in our lab, it's old, but I think it's extremely important. And this was a study that attempted to understand what therapists know about kids' exposure. So they interviewed, well, they collected data, quantitative data, and a little qualitative data as well, with therapists and their clients, child clients. And this was across three residential treatment facilities. And they found that therapists, actually, we can see all of the significant differences here between client report and therapist report. But one stat I want to point out is the stat related to lethal violence. And so, as you can see, you have 29% of clients saying that they had been attacked with a knife or a gun. 3% of their therapists said that may have happened to them. 55% said that they witnessed a knifing or shooting. 10% of therapists reported being aware of that, or that had happened. This is the one, the last one is the one, let's see if I can get my little laser pointer to work, that we come back to, is that over 50% said that they had witnessed a homicide or suicide, but not one of their therapists said that they either knew that they had experienced it or were aware of that experience. And during the post-quant study, where they conducted the qualitative debriefing interviews, some therapists reported that they didn't see the relevance of the child's exposure to violence as germane to the residential treatment work that they were doing with them. which kind of leads into the next lesson that we've learned, which is that there's a lack of training for clinicians around issues of trauma-informed care. So an article that came out last year showed that within clinical psychology doctoral programs, only 9 programs, it's 5% of the programs, required a course on trauma-informed care, and only 8% of graduating students have been required to take any sort of course on trauma-informed care, because it may be outside of their program. But we are lacking in folks who are trained to work with people who've been exposed to trauma despite the high rates of trauma exposure. And so this creates a, in my opinion, it's a perfect storm. You've had work showing that 3/4 of adolescents who've been exposed to violence express a desire to talk to somebody about it, a counselor about it, a therapist. But you have very few clinicians who receive training to work with them. We also know that their exposure outside of their home, if they are receiving care, may be neglected by some mental health professionals. And in general, young people who've been exposed to violence are less likely to receive mental health services than those who have not been exposed, which leads to some more of the work that we've done, which is then what is the impact of exposure on well-being? It is very important to note that different youth are going to respond differently, but these are some of the most common outcomes of violence exposure. We do know that we see strong links between violence exposure and aggression and delinquency. One issue is that some of the early research showed either no association or associations in unexpected directions for emotional distress, particularly depressive symptoms. And I'm going to come back to that in a few minutes. But our work has focused a bit more on what helps us to understand some of these outcomes. And we have focused quite a bit on desensitization. I think I just gave away the next 2 slides a second ago, but I'll repeat it quickly. As I just said, some of the strongest associations for community violence on outcomes involve externalizing disorders such as delinquency and aggression. And we see less consistent associations for depressive symptoms. Many of our stress models propose that the more stress you're exposed to, the worse your outcomes. And so for depressive symptoms, the findings that people were obtaining were not always consistent with those existing stress models. And so that led to questions about whether or not we were seeing, or people were seeing, a desensitization effect for community violence. And what do we mean by desensitization? Well, youth who experience repeated community violence may, quote unquote, adapt by suppressing emotional distress. And so we might see blunted emotional stress that's represented by a curvilinear association between community violence and measures of distress. That's an inverted U that we might see. Why is it important to understand desensitization? There are assertions that desensitization is directly related to the economic and social burden of community violence, such as incarceration, homicide rates. Another issue is that it also impacts our perception of the functioning of young people who have been exposed to violence. One reason I got interested in this work was talking with people who work with adolescents, and I would hear people say, "Oh, I don't think this has an effect on them anymore. They've been exposed to it so much. I think they're desensitized to it." And I really wanted to understand that better, because I felt like people were approaching their work with young people with this belief that violence exposure was not having an impact on them. Some existing one of the original frameworks for desensitization was the pathologic adaptation model. And this model says that the association between violence exposure and aggression or delinquency is linear and positive, but the association between violence exposure and emotional distress, again, often represented by depressive symptoms, is curvilinear. Now, why is this model called the pathologic adaptation model? Well, according to the authors, they talk about it as being adaptive because emotional numbing may be adaptive, at least in the short term, by protecting young people from the negative emotional effects of violence exposure. At the same time, they believe that it's pathologic because through emotional numbing and also cognitions that might normalize violence, desensitization might reduce young people's inhibitions against behaving in an aggressive manner or place them at elevated risk for more violence exposure. So some of our work on this pathologic adaptation model was trying to introduce more longitudinal work. Much of the work when we started in this area was cross-sectional, including some of our studies. And so we wanted to start doing some longitudinal work on this topic. And so we had a couple of studies that had a sample of African American and Latinx boys and their caregivers from neighborhoods in Chicago. I won't go into the specifics of the studies. I'm happy to answer more questions about them, but I just want to point out two key findings. We found that a desensitization effect that occurred from early adolescence to late adolescence, meaning the violence exposure that young people experienced in early adolescence showed a desensitization effect into late adolescence. We also found in the second study that this desensitization effect increased the likelihood of violence perpetration in late adolescence. And I'll come back to that. I don't want to get too far ahead of myself. So, in thinking about these findings, do youth become desensitized to community violence? Maybe. Our overall findings did provide support for that, but there might be some other explanations. We do know that sometimes young people underreport depressive symptoms to facilitate their ability to navigate through neighborhoods or communities where they may experience a number of threats. So particularly when Black boys report that they're more likely to respond to victimization by acting tough or finding a way to protect themselves rather than feeling or reporting feeling depressed. So there may be some intentional suppressing of depressive symptoms. The other issue that we will also talk about in a few minutes is that PTSD symptoms may be muting the depressive symptoms. We know that one symptom of PTSD is emotional numbing. And so what we may be seeing is an impact of PTSD on depressive symptoms. So we were able to demonstrate this desensitization effect over time, but I was still not convinced that we had the full story. And I want to go back for just a minute. So two things happened early on in my career that later influenced my thoughts about desensitization. So these things were happening at a time when I was considered more of a coping researcher. And I was doing focus groups in schools in Chicago to better understand culturally relevant coping. And I was asking the kids what kind of problems they deal with every day. What kind of problems do kids your age deal with? And, across these schools, young people talked about issues that we would expect them to talk about, peer issues, family struggles, economic, financial issues. They also talked some about violence exposure, but there was one particular school where the kids across the multiple focus groups I did in that school, I kept hearing the same phrase, we're trying to get home without getting shot. Now, remember, I was not a violence researcher at that time and knew very little about it. And so I was a bit shocked to hear this. And so I talked to them more about it and came to learn that they had to leave school and there was, many of them lived in a high-rise community a couple of blocks over. So they would have to cross a field to get home. And occasionally someone would, for whatever reason was happening in that community, people would open fire while the kids were getting out of school. And so kids would have to scatter, run, find shelter. And a couple of weeks before I came in the school, there was an incident where there was a shooting and kids were trying to find shelter. And there's an ice cream man that was out, that I was out every day selling ice cream, and he got shot. And I kept hearing the ice cream man got shot, the ice cream man got shot. And for me, the innocence of ice cream, buying from the ice cream man, and this man being a fixture in the community, to it being, up against this, dodging bullets essentially is what he was doing. And it just stayed with me. He lived, but the trauma of them seeing that and experiencing that stayed with me. Now, what I want to note about this school is that there were a lot of fights in the school. And even in my groups with the young people, they seemed to be on edge, very jittery. They were wonderful to work with and talk with, but I could notice that they had a hard time calming down. And I started thinking about this school when I started doing work on desensitization, because I was like, those kids don't seem desensitized to me. They were nervous, they were jumpy, they were on edge. And I thought about that for many years after. Um, Sometime after that, I was doing some work on depression and anxiety and coping strategies, and we were trying to understand the association between depression and anxiety, the overlap between depression and anxiety in Black youth, and understand factors that help distinguish between those two, given that there's high comorbidity for Black youth between depression and anxiety. And I'm not going to go through all the findings, but I do want to point out in this red box, there was a finding where violence, this is community violence, was not associated with the unique depression feature of anhedonia, but it was strongly associated, not well, it was associated with the anxiety feature of physiological hyperarousal. And so as I moved into doing work on desensitization and thinking about that school and also this finding, I started wondering if there were different effects for community violence on depression and anxiety. Most existing studies at that time either focused on depression or combined some indicators of depression and anxiety into this emotional distress score or overall internalizing score. And I started to wonder if this desensitization effect would be different for anxiety versus depression. And so we did a series of studies where we examined separately the effects of community violence on depression and on anxiety. And these studies were with Black middle school students in urban neighborhoods in Chicago. And we did find the first study was, I consider more of a variable-centered study, but we did find that there was a curvilinear association between community violence exposure and depressive symptoms. But the finding for anxiety was linear. There was no curvilinear effect for anxiety. The second study we did was more of a person-centered approach. We did a latent profile analysis of violence exposure items, and we found three groups: a low exposure group, a victimization group, and a high exposure group. And we found that the high violence exposure group had the lowest scores on the depression, or the lowest levels of depressive symptoms. So what does this mean? And we didn't see this difference for anxiety, but we did see it for depression. I didn't know what to do with this for quite some time. And I started talking with folks who do research on media violence. And I found out that there were, in the media violence literature, there are different types of desensitization. There's emotional desensitization, which is what we were studying in the community violence literature, but we were just calling it desensitization. There's also a cognitive desensitization. There's also physiological desensitization. And so what I realized is that we probably need to pull some lessons from the media violence literature and think about different types of desensitization, because that's not what we were doing. We were measuring emotional desensitization, but we were calling it all desensitization. And so we started thinking about this physiological arousal and physiological desensitization. Um, and what that looks like for young people. And it's essentially hyperarousal symptoms that are a part of PTSD: trouble sleeping, difficulty concentrating, irritability, hypervigilance, increased startle response. Those were the things that I was witnessing when I worked with young people in that school. The hypervigilance, the irritability, um, increased startle responses. People were constantly checking their surroundings, showing the hypervigilance. And so we started rethinking what desensitization might mean. Um, Community violence is a traumatic stressor. Unlike media violence, you can't always turn it off, right? And they are events that involve the actual occurrence of death or severe injury through direct experience or witnessing that happening to someone else. So in contrast to most media violence, community violence is largely uncontrollable, it's unpredictable, and it's traumatic. And so we believe that some of the findings for emotional desensitization and cognitive desensitization are probably consistent for community violence and media violence. But we started questioning whether or not some of the work on media violence that was showing a physiological desensitization would be consistent with community violence, and that instead of a physiological desensitization, community violence might produce a physiological hypersensitization. We know that trauma can alter brain functioning in many ways. Some of the most important changes appear to occur in our prefrontal cortex, which, our thinking area that becomes underactivated, the anterior cingulate cortex, our emotion regulation center, that can become underactivated, the amygdala or the fear center that can become overactivated, the hippocampus that helps us to process memories and transform them to long-term memory storage. Sometimes those memories remain in an activated short-term status, preventing them from being properly integrated. So their effects on us will diminish, and so that doesn't happen for young people. And so all of this together might produce a threat sensitization, where young people are always prepared physiologically to respond to stress. It's kind of like being in fight or flight all the time. And so we started thinking about this dual process model of reactivity to violence exposure, where repeated violence exposure may lead to cognitive and emotional desensitization, but it may lead to physiological hypersensitization. But the combination of all of these would lead to more aggression and violence perpetration and more violence exposure later on. We had one study where we tested this dual process model. This was with high school boys, Black high school boys from a school in Chicago. And we assessed these variables using surveys, self-report surveys. Just in general findings. The participants did not show emotional desensitization. It was the first study I've ever done on desensitization where we didn't see the effect. They did show a physiological hypersensitization, though. So we did see that linear association between violence exposure and physiological hypersensitization as assessed by a PTSD measure. We also found that physiological hypersensitization increased violence perpetration over time. So no emotional desensitization. What in the world? I think there were about 4 of us who were doing research in this area at that time. And Paul Boxer was one of those, Maureen Allwood and Sylvie Murrig. And I remember reaching out to all of them, just like, what do you think? I think we all presented at a conference that year together, and I talked to folks about it. And the answer that everybody gave me is like, well, the age of your sample is older than many of these other studies that have been done on desensitization. Most of those studies assess violence exposure in early adolescence, and yours assessed it in middle to late adolescence. We know that there's evidence showing that compared to younger youth, older youth are exposed to more severe forms of community violence, and they're more likely to be victimized. So young people might show emotional desensitization to violence exposure as they move into early adolescence, but as they begin to witness more severe and personally harmful events in middle to late adolescence, they may experience increases in depressive symptoms. This effect might also be due to grief and loss as violence begins to claim the lives of more of their friends and family. We know that older youth are more likely than younger youth to know victims of community violence personally. The homicide death of friends and family members peaks at ages 15 to 17 for Black boys, and this was a sample in my study. So we might be seeing an effect of grief and loss. Again, we saw that there was a physiological hypersensitization effect. And this is, more support for violence exposure being a traumatic stressor, and this mediation effect for physiological hyperarousal. So this kind of hyperarousal induced aggression, which, you all may think about as reactive aggression, right? So kids are walking down the hallway, somebody bumps into them, they just turn and punch. It's just a reaction. And that's a lot of what I was seeing in that school earlier that I talked about, was this hyperarousal induced aggression. And so what are some of the implications, I think, for interventions? Well, existing violence prevention and interventions tend to focus on skills, and so tend to talk about things like hostile attributions or aggressive cognitions, and how can we help kids learn better social problem solving skills or cognitive processing skills or life skills. And I think those are important, but I also think we have to better understand how these hostile attributions or aggressive cognitions may be reactions to trauma. And I think it's really important that we understand the links between becoming emotionally numb and these aggressive cognitions. These might be helpful to protect them from the emotional costs of violence, the fear, the anxiety that comes about, and even the grief to the loss of others. And so we think it's really important to address symptoms of PTSD before addressing the skills. A question that we've been exploring recently is, are we disabling survival strategies through our interventions? And I think this is really important because, a study that was given to me to read some time back by two dear friends of mine, Jocelyn Smith and Desmond Patton, where they interviewed Black men ages 18 to 25-ish or so in Baltimore about PTSD symptoms. And they found that I think all of the men in their sample would have met the criteria for PTSD. But when they started talking with them about the actual symptoms they were experiencing, they found that hypervigilance, which is a component of hyperarousal, was the most frequently experienced symptom. And these young men said, yes, we know we are experiencing that. That helps us. We're on point. So they defined being hypervigilant as being on point. They needed it to be able to stay safe in their community, right? We started wondering if that could be the case. And a more recent study, we set out to understand whether or not hyperarousal or specifically hypervigilance could be adapted. And this was with Black high school students. And we assessed their PTSD symptoms. We looked at the overall hyperarousal subscale, but also pulled out the hypervigilance item. And what we found is that higher levels of hypervigilance at time 1 predicted less witnessing of violence exposure at time 2, and that's controlling for witnessing at time 1. We also found for victimization that hyperarousal, the broader construct of hyperarousal, predicted less victimization over time, but only when they reported high levels of physical aggression. So hypervigilance did predict less witnessing. So increases in their attention towards potential threat might be adaptive, right? It helps them prioritize their maintenance of resources, maybe plan for escape routes, avoid potentially dangerous situations. We also found that a combination of hyperarousal and aggression predicted less victimization. And, our conceptualizations of hyperarousal as occurring in the absence of a threat may not capture the experience of Black youth, particularly Black boys who are in communities with ever-present threats of community violence, of police harassment, of racial discrimination and stereotyping. And so chronic threats in those environments may shape and reinforce the hyperarousal symptoms in a way that promotes optimal stress reactivity in that context. And so again, I mentioned a few minutes ago about becoming threat sensitized. That might be adaptive for that context. There's prior research showing that hyperarousal leads to more aggressive methods of self-protection and posturing or presenting oneself in a way that is believed to be protective. And so what we think is important for this work is shifting from thinking about it as pathologic to thinking about it as conditional adaptation. So the work that we're doing is trying to shift this narrative on young people who've been exposed to violence. And rather than viewing emotional desensitization as callous or insensitivity or an insensitive response to violence exposure, we view it as a protective mechanism from the intense feelings of distress and grief, and a way of coping with events that overwhelm the stress response system. So this continuous exposure to traumatic events. It's been argued that young people who grow up and survive adverse conditions may be more stress adapted. But I think we just want to be sure that we're thinking about the context, because trauma does not happen outside of a context, right? Now, I talked about this model, or talked about these behaviors as being adaptive, but I think what we have to realize is with this conditional adaptation concept, it means that you show behaviors that may be adaptive in one context, but maybe not so much in another context, right? So perhaps, and we see this a lot, where kids show certain behaviors, hypervigilance, hyperarousal, posturing, to get from home to school. But then in school, that may not be behavior that is helpful in that context. And so then we start seeing kids getting in trouble for showing certain behaviors that have been adaptive in other contexts and also responses to trauma. I think it's really important that we shift our understanding, because pathologic frameworks lead to Black youth being overdiagnosed with socially disruptive disorders, disproportionately suspended and expelled from schools, and overrepresented in the juvenile justice system. I know we're running a little short on time. I'm going to skip the clinical slide. If anybody's interested, I'll come back to that. But I'll talk about some next steps in our work. And what are the age and gender effects on curvilinear associations? Most of my work has been with boys, not on purpose. Those are just the opportunities that kind of fell in my lap in our research team. And so we are now, I've been saying this for a few years now that we want to get this work started, but we have finally gotten access to data sets that allow us to do this. And we have data analysis ongoing now, where we're trying to understand these same effects in girls, and also whether or not that age effect is a thing, right? Are we more likely to see emotional desensitization in early adolescence versus late adolescence? Another question we're working on is, what are the long-term effects of hyperarousal and hypervigilance? We've talked about it a few minutes ago about it being adaptive, but what does that do to your body if you are constantly in a state of fight or flight? Over time, that's going to wear down your body. And so we have some work that we're working on to better understand this effect, particularly for Black men. And moving into trauma-informed interventions. So we want to make sure that these are contextually relevant and culturally relevant. We want to make sure, I mentioned about disabling survival strategies. We want to make sure that young people believe that the components of the intervention are relevant for their lives. There's some work showing that young people, certain components of interventions, some work showing that youth have little confidence in nonviolent solutions, and in some cases believe that these strategies will make the situation worse. And so how do we then work within contexts where it may be necessary to protect yourself, to be hypervigilant, to be on alert. And we also have to attend to this issue of continuous trauma. Our definitions of PTSD assume that a person has experienced a traumatic event, they've been exposed to violence, and then that threat is over. And if they continue to show these symptoms, it's maladaptive. But as my dear colleague Jocelyn Smith says, what about a world where there is no post? Because for some individuals and young people that we work with, there is no post. There's continuous exposure to violence, and our interventions have to account for that. We need more work on grief and loss in young people. And also, we need to be able to better distinguish between ADHD and disruptive behavior disorders and PTSD, because some of the symptoms overlap. And we have seen kids within our clinical work that have been diagnosed with disruptive behavior disorders when it is really PTSD. Another area of work that needs to be explored is the use of substances as a way of coping, like self-medicating to deal with the trauma. And I think, yes, I'm going to stop there because I know we're running short on time. But these are some ways to connect with us. So please reach out